Welcome to all of you all over the world. My name is Mira Vernooy and I am the chair of the IPA webinar series. Our webinars are, in our webinars, we try to present actual and urgent topics, and today it's Human Rights Day, so it's very actual to have a webinar on human rights. And we also like to collaborate with other organizations, and today it's the World Psychiatry Association, and we are very happy with this collaboration, and we are very happy to work with Dr. Carlos de Lima, who is the key organization of this webinar. He is the chair of WPA section on old age psychiatry, and he is based in Switzerland. Our keynote speaker today is Professor Israel Duron. He is a law professor and he is specialized in aging and social policy, and he is based in Haifa. We are very happy also to welcome Professor Norman Sartorius, who is a former director of the WH Mental Health section and he was the chair of the WPA. And he is called Psychiatry's Living Legend. So we are very honored that you are joining this webinar, Professor Sartorius. We are also very happy with our moderator. It's Dr. Kiran Ribeiro, and he is a member of the board of the IPA directors. He is a geriatric psychiatrist, and he is based in Canada. Well, as I announced, today it's Human Rights Day, and human rights are supposed to be universal, but that is not the case. Human rights are threatened in many people because of some characteristics such as age, gender, the color of the skin, social and economic status, and the mental condition. So we have a very important task in human rights defense. And therefore, this webinar is dedicated to the defense of universal human rights. We will do so not only with a keynote speaker, but also with a dedicated comment from Professor Sartorius and with a panel discussion. And later on, the floor is yours in the Q&A, and I really hope you will use it. And for now, I hand it over to Dr. Ribeiro.
Greetings, everyone, and welcome. Thank you very much, Mira, for the very kind introduction. As was mentioned earlier, today is the International Day of Human Rights, and we know that human rights have been violated significantly over the past few months, especially for older persons. And so to bring this to light, we have this collaboration today. I would like to make sure that you all have a chance to ask your questions. Please post them on the chat box. We will start with Dr. Carlos Lima. Carlos is as was introduced earlier, he's the WPA, World Psychiatric Association chair of old age psychiatry. And he's going to talk initially about why this webinar.
Good morning, everybody. At the end of these two talks of Professor Sartorius and Professor Doron, I would like to complement this with explaining why this webinar was necessary and justified it for you all. You know, International Psychogeriatric Association represents the geriatric mental health care professionals dedicated to improving the mental health of old people everywhere through the advancement of education, research, professional development, advocacy, health promotion, and service development. WPA, which was founded in 1950, has as vision a world in which people live in conditions that promote health, mental health, and have access to mental health treatment and care that meet appropriate professional and ethical standards, integrate public health principles, and respect human rights. At the present action plan, Professor Afzal Javed, the president of WPA, has mentioned a list of some priorities, and one of them is developing partnerships for collaborative work and strengthening partnerships with mental health and other organizations. This includes for us of the WPA section of Old Age Psychiatry, a strength collaboration with IPA. You know, the United Nations Declaration of Human Rights, published signed in 1948, is a document, a valuable document, a very important and valuable document for us in mental health, because its articles allow us to develop the ethical standard of our practice. At Article number 1, it is stated that all human beings are born free and equal in dignity and rights. They are endowed with reason and conscience and should act towards one or other in a spirit of brotherhood, the same spirit that is in the base of the vocations of staff working in mental health, and mainly in mental health for old people. The Article number 2 states that everyone is entitled to all the rights and freedoms set forth in this declaration without a distinction of any kind, such as race, color, sex, language, religion, political or other opinion, national or social origin, property, birth, or other status. I have a deep regret that in this list is not include age, because age is today clearly a topic that is the origin of discrimination and stigma. And we have to protect those who are aged against both stigma and discrimination. The Article number 3 states that everyone has the right to life, liberty, and security of person. So no distinction can be done in mental health care based on age, because all have the right of the same opportunity of care and treatment. But during present difficult times, these principles have to be recalled. They are more than necessary for us. Pandemics, wars, and natural disasters and other crises may reveal the best and the worst of mankind while struggling for survival. We all can choose selfish individual response to this crisis, or prefer to empathy, compassion, and solidarity. This is bases the principle of dignity in mental health care. Depending on our choice, we can develop and promote this dignity or not. What is dignity? Dignity is being valued or having worth. In mental health care, dignity sustains the ethical and the legal framework that supports someone's losing his or her autonomy and independence as a result of mental health problems and other comorbidities. The non-inclusion of the principle of dignity in mental health care for all adults may result in ageist attitudes and behaviors, at the development of better mental health policies, programs, and service, and finally, the poor access to health and social care for those who are in need. The United Nations has stated some 4 strategies during these times of COVID-19 pandemic to sustain dignity in care for older adults. The first principle is to ensure that difficult healthcare decisions affecting older people are guided by a commitment to dignity and the right to health. The second principle is strengthening social inclusion and solidarity during physical distancing, increasing the sense of belonging and reducing loneliness and isolation. Third, fully integrate the focus on older persons into the social, economic, and humanitarian response to the COVID-19. And finally, expand participation by older persons, share good practice, and harness knowledge and data. So now than ever, more than ever, mental health illness has to be considered as a way to kill people. Mental illness in older adults kills, but the disrespect of older adults' human rights kills too. And this is the main justification for celebrating today and recalling everybody that not our role as professionals is not only to manage mental illness, but to manage also the human rights of our patients. I invite you all to become a member of this WPA section of Old Age Psychiatry. To apply, you can access the WPA website, choose the leaflet section, where we will find the link to join a section and submit your expression of interest here. So I thank you very much for your participation and interest in this webinar, and I'm ready for your questions. Thank you very much.
Thank you very much, Professor. I'm going to invite now Professor Israel Doron, who's the head for the Center for Research and Study of Aging at Haifa University, to talk about the human rights and mental health of older persons. Can we learn anything from COVID-19 crisis? Izzy, please.
Hello, everyone. My name is Isi, Professor Israel Doron. I'm a gerontologist or a jurisprudential gerontologist, meaning I specialize in the fields of law, aging, and human rights of older persons. I would like to first begin and thank the organizers and the funders of this excellent meeting and for giving me the opportunity to present shortly my perspective in this context. This presentation is about COVID-19. The COVID-19 is an opportunity to revisit the human rights situation of older persons in general, and in the context of the rights to mental health in specific. Again, in this short presentation, I will be only able to present my key perspectives, but I hope it will open the door for further discussions, thoughts, and insights further down the line. Let me begin with the basics from my perspective on our topic today. First of all, the broader perspective on the human rights to health and mental health. We all know that under the general framework of the classic Human Rights Convention, we have Article 12 of the International Covenant on Economic, Social, and Cultural Rights, which specifically and directly addresses the human right to health, including the right to mental health. So as Article 12 states, the state parties to the present covenant recognize the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. So since the 1950s, we have recognized the awareness, acknowledgement, and a binding framework which recognizes the human right to mental health in general. Plus, we have further down the line a general comment number 14 of that covenant, which defines and explains and further elaborates that the right to health includes 4 elements: the availability, the accessibility, the acceptability, and equality and quality. So as you can see, the human right to health on the international level is well recognized, so to speak. However, when we move to the more narrow aspects of our discussion today, it is first of all important to recognize that unlike women, children, or persons with disability, there is no binding global international covenant on the rights of older persons as such. We do have 2 regional, relatively new regional conventions. One is still not in force, the African Union Protocol, but we have one which is in force, and that is the Inter-American Convention for the Rights of Older Persons, which I'll touch later on, which once again does include the right of health in general. We do also have various instruments which are soft law in the context of the rights of older persons. However, none of them is binding as such. Now, when we move very narrowly to the specific right to mental health in old age as a human right, once again, it's very difficult to find any specific reference to that human right as such. As we don't have any general global convention for rights of older persons. However, for example, in the Inter-American Convention on the Protection of Human Rights of Older Persons, once again, in the general article which regards to the human rights to health in old age, once again, we can see the similar reference. So older persons have the right to physical and mental health without discrimination of any kind. So once again, we can see that if and to the extent we have a reference to mental health, it is usually within the broader context of the right to health in general. And generally speaking, within the context of older people as a unique and specific group, generally speaking, I would say that the bottom line, there is a symbolic and normative gap in this field as we lack both specific references on the international human rights documents to this issue. And furthermore, there is a general lack in international human rights case law, so to speak, and precedents on that front in specific. Now, if we move from the general and a very broad context and move more specifically to the pandemic of COVID-19 in the last several months, once again, I think we can say a few broad and general statements and arguments. First of all, I think there is a growing body of evidence showing that human rights of older persons as a group were highly violated during the recent months of the COVID-19 pandemic. Again, in the short time, I cannot provide you the full picture, but in general, for example, during the COVID-19 crisis, there have been many examples of discriminatory provisions using old age limits, so discriminating between young and old based solely on chronological age, disregarding totally the individualistic aspects of people and infringing the fundamental right to equality. We have also witnessed, especially in nursing homes and residential care setting, a huge crisis resulting in large number of older people dying in these institutions due to lack of sufficient care. COVID-19 also intensified the phenomena of elder abuse and neglect, happening all in a general and broad public climate of intolerance and hostility to older persons. So once again, these are just some examples of a very broad social phenomena of what I would call a rise in ageism, which we have seen during the last months of the COVID-19 crisis. So, what has happened in this period with regard to mental health in specific? Again, as this is not an empirical study or research, I would try to argue that there is an accumulation and a combination of several different phenomena which all work together in the context once you have to realize what we are talking about in the context of human rights of older persons during the COVID-19 with regard to the right to mental health. Again, I think we have seen a significant rise of ageism, stereotype, biases, discriminatory practices, a general public discourse on the public media, television, etc., which portray older people in a very stereotypical manner, on the one hand as those who are to blame for all the closures and we are paying the price of protecting them, and on the other hand their vulnerability, their being a risk group, etc. So there's a whole range of ageist discourse on the public media these days. But it's not only a portrayal or ideas or media coverage, it's actual policies and practices. Again, starting from a labor force to healthcare, to rationing, to choices about who will and who will not receive ventilators or vaccinations, etc. We have seen many examples across the globe of how countries and societies discriminate, exclude older people simply because of their chronological age. Adding to that, we have all seen the policies about social disconnect, closures, social isolation, which again, it was many times universal, but in specifically, many times those who were hurt most significantly, for example, in the context of loneliness, were many times the older populations. Once again, we've seen various specific public age-specific restrictions, as I mentioned. Adding on to all of the above, one could also make reference to the digital divide, because in many cases, countries have societies in the context of social distancing have turned into technology, internet, etc., as a solution for these distancing policies. But in light of the digital divide, many older people were not able to use and to receive assistance and help and solutions on that front. Finally, I think, again, all the social policies which were taken as measure of protections, the outcome was significantly reduced ability to access to medical services, specialist services in general, and in mental health in specific. So, all of these issues and all of these aspects, when we add them on together, I think have brought to a potential result in the following. I think many older people may have experienced a thwarted sense of belonging, a perceived burdensome on the society, minimizing the importance of mental health in general and for older persons in specific, a greater risk of symptoms mentally and physically which are being undetected and or untreated in such a context. Older people internalizing the messages of ageism, which again go and affect their health and well-being. Potential increases in phenomena of psychosis and suicide. Older people along this process being totally invisible in the process of formation of mental health policies. Again, resulting in social and legal barriers to mental health services and discrimination and exclusion from services and from society at large. So the bottom line, again, generally speaking, one could argue that the potential for significant harm to the mental health of older person is only a natural result of this reality of the COVID-19. Now, what do we know as a matter of fact? Naturally, there is a need for much more research and evidence to provide an accurate picture. Unfortunately, while there is more and more publications of some findings and research, generally speaking, we still don't know the full picture. And specifically in the context of mental health, we have some conflicting data in this field. Some examples and some case studies and some reports do report of rise in the anxiety disorders, stress-related disorders, or depression in older population. However, on the other hand, there is a growing body of evidence which actually shown that compared to younger people, older persons living in the community, I should stress, are mentally more resilient and show lower stress-related mental symptoms during the last months. So, undoubtedly, we still need to improve our data collection, to improve our data analysis, and to get a better picture of what is the reality in real life. So where do we go from all this data and this accumulation of very different both arguments and data? For me, there is a lesson that can be learned from the COVID-19 pandemic in the context of human rights in general, and then the right to mental health of older persons in specific. And this is my insight. First of all, I think that there's not only a gap, but a real absence and lacuna, so to speak, in the human rights discourse, meaning the language, the advocacy, the legislation, the awareness, and the policies regarding the human right to mental health of older persons in specific. The reality is only, this reality is only a manifestation of not only ageism, but the intersectionality of ageism and ableism. So in this sense, it's a unique situation. Therefore, we must be aware of the importance and significance of this intersectionality aspect, the unique combination of both ageism and ableism, and the conjunction of stigma and ageism, aging, and stigma of mental illness. So it's the combination of both our social construction of old age and the social construction of mental illness or mental health together, which makes a unique and distinct combination. We must then push forward in our efforts to advance a new and unique international convention for human rights of older persons. And in this futuristic new and novel human rights instrument, as well as in the already existing human rights convention, we need to better articulate, better define, and interpret the actual meaning of the human right to mental health in old age. So, once again, thank you very much for listening, and I hope that this presentation will enable us to further this discussion and to improve our insights, knowledge, and understanding of the human right to mental health for older persons. Thank you very much.
Thank you very much, Professor Doron. And now I would like to invite Professor Sartorius, who is the president of the Association for Improvement of Mental Health Programs from Switzerland, to give us a few minutes of his time to tell us about any perspectives that he has on this topic. Professor Sartorius.
Thank you very much for inviting me to participate in this event, which I consider to be very important because it reminds us of the human rights of the elderly, which are very often not taken as seriously as they should be. I was invited to make some comments on what the speakers before me said, and I tried to do that by first referring to the very point that has been mentioned several times, that we should have a special covenant, a special document, which will speak about the human rights of the elderly, human rights of old people. I think it would be a terrible mistake to have it. I think human rights are rights of humans, and elderly people must be considered human, not somebody else, some other group. They are humans, and then the elderly. So I think it's of great importance that we fight for the rights that belong to old people, but we should not seek a separate document, a separate statement, which would separate them from the rest of the people. They are part of humanity. They are an important part of humanity. And as such, they should enjoy all the rights that other people enjoy, all the rights that everybody who is human should be enjoying. My second point is the very important statement about some of these documents which speak of the how much health should we offer, how much health should be our goal. And how much health should be our goal is an interesting question. When in 1978, the countries of the world united to look at the possibility of providing a document that would look at primary health care being offered to everybody in the world, everything was going fine until somebody, a government, suggested that in addition to saying that this should be the best primary care that can be given, they added one word, and that was the word was affordable. Affordable. That care should be as good as the countries can afford to make it, which of course puts the rest of the document at shame, because what can be afforded or what is being put forward as being important expresses the scale of values that people have. So when we speak of highest attainable or highest affordable, it means that we are allowing the political process and others to decide how much really health is worth. Is it better maybe now to look at something else? Maybe building roads is more important than health, because once the roads are built, there's no more money. So the health cannot be, we cannot afford that level of health. And it's of tremendous importance that we think very carefully of the four descriptors of affordable or attainable health. Number one, that health should be accessible. Being accessible is not only that it is there somewhere. People should have this health in the closeness so that they can approach it when they need it. It should be also acceptable. I think that is very rarely accepted as a rule, that we should in fact ask people whether the type of health that is being offered to them is health that they want, healthcare that they would like to have, healthcare that they would accept as theirs. It should also be available. That is the third characteristic. That is, there should be enough of it, and should be enough of it to be able for people who need it, get hold of it, and in fact benefit from it. And of course, there is a necessary qualification that healthcare must be of quality that is acceptable as well. So these are the characteristics, but I think the third, just to speak about the word attainable, somehow forgets these various components of deciding on what healthcare we should offer to people. Now, what did the COVID, which was also mentioned here, illustrate maybe better than anything else? It illustrated two things. Number one, that in many instances, for example, the beds for the mentally ill were taken away from that and given to the COVID people who had suffered from COVID, because mental health care was at that point considered less important. Why just mental health? Why not have given away beds that have been there for people with crooked legs, or people with a diabetes or some other disease? No, it was mental health beds that had been taken and put into this. And I think it was an indicator of where the priority lies and what is being done in the terms of where the health resources are being put. But more important than that is the COVID has demonstrated a fairly complete disregard of the emotional needs that people who are not well or people who are well might have at any age, including old age. One of the main complaints that people had is that any relationship which they had with both on the side of the elderly who were in the homes, for example, and those whose relatives have been in the homes, has been that they are not allowed to see each other. They're not allowed to speak to one another. And there were numerous ways in which that could have been done under safe circumstances. But since this is just an emotional need, it was not considered sufficiently important. And I think that that's one point that we should really consider as being of central importance, that it is not only the need for physical care, but it's the need for the emotional expression that is also very important. There's a book that is now making, I think, very good sales, which is called The Rabbit Effect. And this rabbit effect is in referring to a particular experiment in which some rabbits have been taken and given a terrible diet. You know, sometimes people do this. They gave a terrible diet, which made these rabbits very quickly have heart problems. And all of the rabbits had the health problems, except for a small group of them. A small group of rabbits didn't seem to have these heart problems, although they were eating exactly the same food. When they started looking why this might be so, they discovered that the group of rabbits, all of the rabbits in the laboratory, were in fact looked after by several people. And there was one group of rabbits which was looked after by a young lady who liked her rabbits and who spoke to them and maybe opened the door a little bit longer and, so to say, cuddled one or the other. And for reasons that are not physiological in the classical sense, it turned out that these rabbits were not dying. They were not dying because they were given an emotional support, to their existence, and emotional support for their life.
2 minutes, Dr. Sartorius.
One just last point, and that is the difference between the recent laws that have been put forward in China, for example, and in Bangladesh, in which the young successors, that is children, have to look after their elderly. And if they don't do this, they will go to prison or be otherwise punished. It was necessary to put in a law for a son to look after his father or mother in a country that is supposed to be built, both of them supposed to be built on the traditional support of the old, support of relatives who are in age, support of the elderly. It has not happened. And I think that that is a symptom that is of tremendous importance, which we should keep in mind. It is the need to reestablish the relationships in society, human and social relationships that will ensure that we have a situation similar to that is prevalent in the Scandinavian countries. Scandinavian countries say the government has a sacred duty to look after all needs of elderly people, so that children of these elderly people can and should be in contact with them and have emotional links, but the care for them is an obligation of the government. And since the Scandinavians believe in their government, number one, and number two, since they pay huge taxes, they believe that that is the way in which it should be done. I think that they are right in many ways. Society must look after the elderly and must look after them in a decent way, respecting their rights and their dignity. Thank you for listening to me.
Thank you very much. Thank you, Dr. Professor Doran, Professor Lima, and Professor Sartorius for your very thought-provoking opinions and ideas. We have a lot of questions that are coming through, and most of them actually have to do with two themes. One is that stigma has been a big driver, if you like, during COVID-19. The unprecedented human calamity of the COVID-19 pandemic has been disproportionately felt by older persons around the world. As the old saying goes, what you permit, you promote. No sector of society must be permitted to be complicit in promoting devastating violations of human rights of older persons. The current human rights framework has not actually been helpful in this way. And there's a pandemic of ageism. I would like to invite each of you, starting with Professor Doran, to speak about how we can actually bring this to fruition so that our rights for older persons are protected, particularly with respect to the convention. I see that there's a difference in opinion here. Some people feel strongly that there should be a convention, and Professor Sartorius said that that's not necessary. Professor Doran, can you start this discussion? And we'll give each of you maybe a couple of minutes to talk about this.
Sure. Thank you once again for giving me the opportunity to participate in this important webinar, and thank you for all the participants who are with us today and for the excellent questions that were raised. First, I would like to respond to Professor Sartorius' comment about the need for a new convention, as well as using this opportunity to answer the questions which were raised. Nobody doubts about the universalistic nature of human rights in general. However, as we know in history, in the last 50, 60 years, the international community of human rights all over the world, both on the international, regional, and national level, have developed specific human rights instruments for children, for women, for people with disabilities, and other groups. So why was that? If indeed human rights are universalistic. So I think on the symbolic and cultural level, we understand that historically there are specific groups within society who have experienced for various reasons, for example, sexism or ableism, a long history of discrimination, of stigma, of other social phenomena, which necessitates within the broader context of our understanding of the universalistic nature of human rights, a more nuanced, a more focused, a more direct approach to the specific human rights of these groups. And the fact that we don't have such a specific instrument which does exist for other groups is yet another proof of the phenomena of ageism, our social construction of old age and our stereotypes about this. So very shortly, and I know we have a short time, just 3 quick notes about it. First of all, symbolically, the invisibility of older person within the context of broader human rights instruments which do recognize the unique interests of other social groups. Secondly, on the substantive issues, in reality, we have various normative gaps in the human rights of older person in the existing system. And there are various examples, either in, for example, guardianship or elder abuse and neglect, of rights of persons with dementia, of rights of people in institutional care. And finally, on the practical level, as a tool for social change, if we do want to change the reality regarding the actual discrimination and daily experiences of older persons about ageism, we need something to work with. We need a binding legal instrument that will force government to change and societies to transform the way they behave towards older people. And now moving to the questions which were raised and the points that were raised, I think that the recent months have been a good example from my perspective why we need such an instrument, as and since the existing human rights frameworks failed to protect the human rights of older persons as were described in the presentation in the time of COVID-19. So what do? I think it's time for what I call ageism. I think there is a real urge for grassroots activism within the older people population, NGOs and groups, and to what my colleague Sylvia Perez called to radicalize the elder rights movements. We need to understand that without a grassroots power and struggle, reality will not change. And I must admit that, again, from my Israeli perspective, we have seen really new signs of this ageism during the COVID-19. More and more voices of older people voice their activism in public media, in protest, in advocacy, in public appearances, saying, stop, treat us differently. Stop, treat us as if we are incapable, vulnerable, without ability to care or decide for ourselves. We are here, hear our voice. So I think that alongside of the various numbers of example of ageism and discrimination, I think the COVID-19 was also an example of the rise of a new social movement.
1 minute, easy, please.
That older people will not accept ageism in society. Thank you.
Thank you very much, Izzy. I'm going to, just for the sake of covering a few more topics, maybe we can come back to this topic. I know it's important, and we can spend a lot of time on this particular topic, but there are some specific issues that have come up, questions come up with respect to the intersection of ageism and mental health in the time of COVID. And I'd like to direct this question to Professor Lima, if that's okay. Carlos, we cannot see your face. Can you just move your screen? That's better, thank you. The jeopardy is double, as you mentioned, when older persons are mentally ill and they're subjected to all the atrocities that we've talked about. How does one protect their human rights? Can you take a couple of minutes to address that, please?
Yes, we have, I can see myself. Are you seeing me?
It's better now, thank you, yeah.
We have discussed it some years ago when we had produced a consensus statement and consensus document on reducing stigma and discrimination against older people with mental disorders. We have seen that the stigma, in fact, is a normal human reaction to what is strange to us. But discrimination is the impeachment to access to the rights because of some reason like age. The stigma should be combated by education of people. Discrimination is an affair of legal and legal affair, laws, protection by those that can assure the rights of people. Legal instruments, advocates, justice is affair of justice. So you have to promote those things. We have to promote first the education of public education, what is to become age, that the age make parts of our life, and that we have to cope and accept this process of aging that starts when we burn. Not when we have 65 or 78. We are always becoming older and older. Secondly is to create instruments to combat all kinds of discrimination that people can have. So education and the legal and other sectors contribution can give in all society to protect those in need. I would like also to recall, to come back to this point of the why a new convention on human rights for the people. That we cannot forget that in 1948, when the convention was signed, the demography was quite different than now. We have almost today 20% of the world population with more than 65 years old, when in 1948 it's not the case. So I can understand why in 48 people was not paying so much attention to old people. But now, old people, yes, to Professor Doron, old people in majority contributing for society. They are not maybe in the working market, but they contribute by taxes, they contribute by their effort to maintain society together. They have knowledge, they have traditions, they maintain education for the children. So they play a major role in our society today. And this role has to be recognized, it's not enough. It has to be recognized by support, financial support and other support, and even by the access to a good care, as Professor Sartorius has mentioned. So I think that the stigma and discrimination may be protected by the free discussion. Every society has their priorities, and each society should at least consider the debate for improving educational means to protect old people and create conditions to reduce the discrimination against them. Thank you.
Thank you, Professor Lima. Professor Sartorius, the next question is for you. And it is sort of wrapped up with what we've been talking about so far, but the comments, I'm just synthesizing a few comments for your consideration. The comments have to do with implicit biases that we all have, and how they're playing into the fuel that's actually ravaging our older population at this time. Some might say that the fact that we're not considering a convention on the rights of older persons, is itself a symbol of stigma itself. And the context in which I'm reading this is that older people are not all homogeneous, that there's basically three groups of people that actually compose, that constitute older persons. One is the healthy older persons group of people who are independent, who live a good life, and that's fortunately the majority of us. Then there's the second group of people who are vulnerable, who are frail, and at risk for developing physical, mental, and social situations that are not pleasant. And then there's a third group of people who are actually very ill, both physically and or mentally ill. Can you comment on that aspect, that maybe perhaps our own stigma when we look at ourselves in the mirror in the morning plays a role in the kinds of comments and decisions and resource allocation that's going into this equation? Professor Sartorius.
Thank you. Well, first to say, I'm not against the convention. I'm against having conventions for every subgroup of people. I think that old people are human, and being human, they have to get all the rights that other humans have. That is my point. Now, we should fight for the realization of their rights. We should not create new documents. We should at least get what we have now, which would be of great importance for us. Concerning stigma, I think that it's important to recognize that there are three components at least in stigma. One is the structural stigma. That is, what do the laws say which is unjust to one particular group of people? We can correct that because we can study the law and find ways to improve it where it is wrong. The second group of stigma is what is called courtesy stigma. That is particularly applicable for mentally ill people, where the family of the mentally ill is also stigmatized, like the person who is ill. Fortunately, this courtesy stigma does not exist for the elderly, because their children are not stigmatized by the fact that they have a long surviving parent. But the third type of stigma is also important, and particularly that one is where we could do something, and that is what is called self-stigma. The person gradually, by being hit from the outside, by all the prejudice and terrible things, loses confidence in oneself and stops fighting and saying, wait a minute now, I am somebody and I have the right and I want to fight for my rights. I want to be somebody. So that from our point of view as healthcare professionals, we could certainly put emphasis on creating, maintaining, and strengthening the self-confidence of the elderly, who should not give up, so to say. In many places, this is difficult because they're discriminated and other things, but I think it's an important area of work where we could partially reduce stigma. So it's structural stigma which we can reduce, and self-stigma. The other one is more difficult to handle from our point of view. Finally, to say the three groups that you mentioned earlier of the people who are, so to say, the elderly well, and then the elderly less well, and the elderly miserable who are also sick and have everything, that is a terribly important point, because that is equal in the whole of the population, that we have these three groups of people. And we have to start thinking of making society deal with its obligations to all three groups of people in this respect. Just to say, maybe to end on a positive note, I'm very much for what Dr. Lima says. Yeah, the number of elderly is growing all the time, and sooner or later they'll become the majority, and then they can vote and they will do things that other things, particularly these young and women and everybody else, will not be able to tolerate. So that is a good thing. And then a little symbol that we have here, which is also important, and that is that in Britain now, the priority of all groups of the population for vaccination and saving life has been given for the old. Not for the sick, not for healthcare workers, but for people who are of a certain age. I think it's in this way where we are thinking all that is not being done, it's an interesting choice that has been done by at least one government in the world to think, yes, these people are valuable. We should protect them. We should do something about their lives. I wish the other governments would follow.
Mm-hmm. Thank you. That's a very thoughtful and reflective answer. I really, I see people appreciating that. We only have 5 minutes left and we need to wrap up soon, but that's enough time to make a few more comments. This goes back to you, Professor Lima, or anyone else on the panel. And it's about the UN Convention. It says the UN, and this is from Miss Margaret Gillis, who is the president of the International Longevity Center here in Canada, who I know well. The United Nations Conventions on Women, Persons with Disabilities, and Children have had a very positive impact on their rights as recipients. Given that, why would a convention on the rights of older persons be any different? Professor Lima, just if you can address it in 30 seconds or...
In 30 seconds, I agree with her that it's useful to have a convention for people, but we don't have to forget that creating this convention means create inside the United Nations organism, means to control if the convention is being applied, which are the means we will give to people to see in each country the convention is being applied, and which are the solutions that if a country is not respecting a convention, what will you do with this country? So it's not just to create a convention, but also to discuss how we will manage this convention in the future.
Thank you. Any 30-second comments from Professor Doran? Sorry, go ahead.
Said, I think that it's terribly important that we try to implement this convention as well as any new convention, that we try to make sure that what is currently already written in the various documents is applied. That would improve the lot of people worldwide to a great extent. So I think that that's something where we could concretely act without delay.
Thank you. Thank you. Professor Doran, any comments from you about that?
Two comments. One, the illusion that existing instruments are enough have been empirically examined and proved to be wrong, in the sense that we have a long history of empirically proven infringements of basic human rights of older persons under the existing human rights instruments. So we know that we have a gap and that the existing instruments are simply insufficient. Mm-hmm. Two, I think we should also not underscore the educational and symbolic importance of such a convention. Again, there's a huge need for a social transformation, and one of the ways, an effective way to transform societal attitudes, biases, and stigma is such an international, global, specific and unique instrument in the human rights of older people.
Thank you. Thank you very much. I see that we are drawing to a close. I will give each of you a few seconds for any last minute comments, and then I will wrap up. So we have 2 minutes. Professor Lima, any last minute comments? Please take a few seconds to say them.
I think that I would like to thank you for this collaboration between IPA and WPA, and hope that in the future we can discuss with other associations too. And I propose here to think if together we could prepare and publish a position statement, a position paper on what we really think about the need to protect the rights of all people with mental illness. So I propose this, that IPA and WPA can work together with others to produce this paper.
Thank you. Professor Sartorius?
Well, I certainly support, I think that not only with WPA, the World Psychiatric Association, but the IPA and maybe a number of other organizations would co-sign a statement that we could make, and that would sort of give additional support to the implementation of things that already exist. I think that we have before us very clear examples of what things could be changed in current situation with current resources. And we should, I think, probably also think of a hierarchy of what we want to do, not thinking that we can do everything at the same time, but what are the things that can be done almost with the resources that we now have, which could be done better used and which could be done better. Let's start with that and gradually build up. And by the time that we get to a special convention and the world is a much better place, we'll do everything. But now let's start with something that we can do today.
Thank you. Professor Doran, we're technically out of time, but please take 10 seconds if you don't mind.
I'm holding in my hand a newspaper from Israel in March with four of the general manager of the largest hospital in Israel saying the following: if there will be a moment where we will have to choose between an elderly 90-year-old woman and a 50-year-old man who is sick, undoubtedly we will give up the older women and prefer the 50-year-old man if we have lack of sufficient number of ventilators in COVID-19. I don't think we want to live in a world that we give up a 90-year-old woman simply because she's 90-year-old and prefer a 50-year-old man.
Thank you. We are completely out of time, but I'll just thank you all for joining us today. There are some incredible comments, some really good questions that we couldn't get to. I apologize for that, but they will be taken into account. Our office will collate them and hopefully we can respond to them. There's some really good ideas about how we can move forward with this on the chat and the Q&A. I would like each of you to take a few moments and do your evaluations on the webinar. We really appreciate any comments that you have, and we look forward to a follow-up. There's comments about perhaps we should have an updated webinar on the state of advocacy for a convention. There's a lot of momentum that's been built up. And I'll just finish up by saying there's never been more older people on this globe than today. There's never been this level of a pandemic of ageism that's actually ravaged this population. And third, we all agree, whether through a convention or not, that we need to do something about it. So on that note, thank you and have a great day.
Thank you very much.
Thank you.